Good morning. This is a quick review for chest tubes and trauma. First thing I want to talk about is the pneumothorax. So what exactly is it? It's just when air enters the pleural cavity, or there's pressure in the cavity which causes the lung to collapse. So it can be open or closed. So air enters through an opening, or there's so much pressure that it causes the lung to collapse, which would be closed, and we're going to talk more about those. You also can have a hemothorax. You can have a hemopneumo, where you've got blood in air, and the hemo is just blood that goes into the pleural space, usually secondary to trauma. As far as the hemothorax is, you'll get a chest tube. You'll get a chest tube with most all of these. Occasionally there'll be a really small pneumo and they'll just watch it, but most of the time you'll see a chest tube. I haven't seen them where they're small pneumos and they just do kind of like a CT scan every couple of days or every day to see, and we're monitoring the patient for shortness of breath and any kind of respiratory problem. So sometimes the doctors will just watch a pneumo, but anytime there's trauma or anything like that, most of the time they end up with a chest tube. So, like I said, open is just air enters through an opening in the chest wall. It could be from stabbing or a gunshot wound or several different things. So anytime there is a penetrating opening that can allow air in. Another thing with the open, sometimes you can have what's called a sucking chest wound, and those are the ones that we put the 3-sided dressing on, and we'll talk. That's also when we talk about the tension pneumo. Sometimes if it's open, then we'll need a 3-sided dressing so that when they breathe in, it doesn't allow air in, but when they breathe out, it allows the air out. So that's what the 3-sided dressing does. Most of the time you will need a chest tube, especially with that. Diagnostics for this, of course, we're going to need a chest x-ray. Sometimes they'll do a CT depending on what the trauma was, but the chest x-ray for sure. The closed one, there's really no external wound. It's just that air enters the pleural space because it's disrupted. This pleural space is disrupted from increased pressure, and that could be from blunt trauma, MVA, that kind of thing. Clinical manifestations, you're definitely going to see, they could be mild to severe. Like I said, I've seen a patient where they're just watching the pneumo. They're having a little trouble breathing, but nothing major. The respirations are okay, the SP2's okay, they'll watch it. But it can be severe, and they can go into respiratory distress, they can need to be intubated. It can be severe. So we're looking for dyspnea, we're looking for chest pain. Absent breath sounds over the affected area, that's a common finding. Also tachypnea and tachycardia, because if there's some pressure in that chest cavity, what's it going to do to the heart? Well, it's going to cause some pressure there too, so keep that in mind. Some other things to consider, the tension pneumo is definitely another rib fracture, flail chest. And the rib fractures, we see those a lot. You'll see those a lot on the ortho floor. But the rib fractures can damage the pleura and the lungs. And sometimes you'll see that they don't do anything. They just monitor the rib fracture, especially if it's just a fracture and it's not broken. But with rib fractures, pain, of course, they're your clinical manifestation. Shallow respirations, it can develop into atelectasis, where the alveoli close up. And it can also develop into pneumonia because they're just not taking those deep breaths, they're taking those shallow breaths. So with rib fractures, we really need to educate them on pulmonary hygiene incentive spirometer, taking deep breaths, especially, if they're elderly or anybody really. We just need to really concentrate on encouraging them, pain management so that they can take those deep breaths. The CDBs, cough and deep breathe. Like I said, that respiratory management, and then incentive spirometer is IS. So definitely give them pain medicine so that they can get those deep breaths. Tension pneumo, you got air that enters. It enters, it gets trapped, it cannot escape. This can be open or closed. And like I said, with open, you're going to need a 3-sided dressing. But it can be, so much pressure in there that it creates, if you see those arrows, it creates pressure which pushes against the other side. And you see how the trachea is kind of moved, displaced. It can cause the trachea deviation. And the air just can't escape. So like I said, it can be open or closed. They often will require mechanical ventilation because this is an emergency. It's an emergent thing. It can be caused from a clamped chest tube. So if you a patient with a chest tube and they're playing with the clamp and they clamp it, that could be easily fixed. Of course, they may have some residual problems that we have to deal with, but the clamped chest tube can cause it as well. Like I said, it's a medical emergency. And then as far as what you're going to see, of course, you're going to see no breath sounds, right, on that affected side. You're not going to hear anything, no breath sounds. They're going to be in pain, of course. Shortness of breath, dyspnea, tachypnea, all of that, tachycardia, because increased JVD, because again, you've got all this pressure in the lung cavity. It's pressing on the heart. It's causing stress and strain on the heart. So just, it's a medical emergency. As far as treatment, of course, paramedics are trained to do the needle decompression out in the field because it's that emergent. And often when they get into the hospital, they'll need a chest tube. So needle decompression and then a chest tube. Flail chest, as you can see, I marked the ribs. The ribs are broken. It's the ribs. And the ribs are just kind of floating. So it creates a problem with the ribs like that. So several ribs are usually fractured and broken, and it causes an unstable segment in the chest, which can cause the paradoxical breathing. You'll see the paradoxical breathing and increased work of breathing, increased heart rate. You may hear crepitus. They'll have that rapid, shallow breathing because there's a problem there. There's the closed chest cavity is the displacement of pressure, and of course you'll see there'll be some bleeding. This and as you can see, this picture on the right, you can see that tiny little word is inspiration. So you'll see when they inspire, there'll be it'll collapse, and then as they expire, it'll puff out. So that's your paradoxical breathing, and that's because that pressure in there is disrupted. As far as nursing care of the flailed chest, we're going to do airway management for sure. Airway management, IV fluids, pain control, and most likely surgery, because this too can be an emergency. As far as diagnostic for all of these, assessment, visualize. You're going to visualize and movement. Do they have the paradoxical breathing? Is their chest symmetrical? So that's why assessment is so very important. And then, of course, your chest x-ray. Like I said, they may do a CT scan if they suspect multiple traumas, but your chest x-ray is a little quicker than the CT, and it'll show these things. So they, often will do the chest x-ray. And then ABGs. Because ABGs, that's going to tell you as far as their oxygenation status, and do we need to vent this patient? Do we need, do they need a non-breather? How severe is this? So definitely ABGs. All right, so let's talk a little bit about the chest tube. So what is the chest drainage system? Well, it just collects fluid, air, or blood, or all, or both, or all of it. And it collects it from the thoracic cavity. So initially, when they first insert the chest tube, you're going to see some bubbling, because as that lung expands, it's going to bubble a little. And then it subsides. So when we say, the jacuzzi bubbling is bad, if it's bubbling like a jacuzzi there in that water seal or air leak chamber, then that's bad. Because once it's inserted, it should be a closed system. And you might see some titling with coughing or whatever, and that's just a gentle movement. But as far as really vigorous bubbling, that's only initially, and then it subsides. So I've labeled here, or this picture has labeled it. I did not create this, but I borrowed it, and really like the way it was set up, because it's got your drainage chamber marked, your suction control. So either you've got water suction control here on the ocean one, which is the wet. You've got water suction control, or you've got the dry suction control. In the dry suction here, on the right, you have a little suction, a monitor dial there that you can control. The doctor may say, give me, and you dial it to whatever he orders, 20 centimeters of mercury, whatever. And then you've got your water seal in your air leak chamber, which I've already talked about. These chest tubes can be hooked up to wall suction. Usually up here at the top, there's a little spot to hook them up to wall suction. And each suction device, each drainage device has this tube that right here, each of them have that, and it allows for, it's a self-sealing tube, so you can actually draw a specimen if they want to send it off, to the lab. You can actually draw it right with a needle there, and it'll close back up. Just make sure you clean it real good before you draw it out. And like I said, dry, wet, and your suction chambers are either wet with water, you put water in there, or it's dry, like I said, with the little dial that you can adjust on the side over here. So as far as your chest tube, nursing collaboration, nursing care, so you're going to be assisting the doctor with putting this in. So you need to make sure that you kind of anticipate what he needs. That's why we ask, We don't expect you to know how to put these in, but you're going to assist with these. So you need to have an idea that, they're going to need to suture it in. They're going to need an occlusive dressing. Sometimes they like to put Vaseline gauze around there, so you need to grab that, depending on the doctor. It's going to be, aseptic technique and head of bed up 30 degrees. And then they're going to need a chest x-ray to confirm placement, and of course pain control. This is a painful procedure, so definitely give them some pain medicine. We're monitoring our patient, we're monitoring the drainage, we're measuring the amount, the color. Now let me just give you an example. So you have a pneumothorax, you expect blood, right? So the doctor puts in the chest tube, you expect it to bleed, and then it can fill up a drainage chamber depending on how bad they're bleeding in there. And that's initially. But once it's in and the doctor leaves and the patient's sitting there with his chest tube, if it continues to drain and you say, I got 300 out, should I call the doctor? Yes, you should call the doctor, because initially it's expected, right? It's draining all that blood out of there. But if it continues to drain, there's a bleed, and they may have to go to surgery. So just keep that in mind. That is after, the initial drainage, if it continues to have a lot of, I think it's more than 100 or more than 200, I believe what your book says, then you would call the doctor. And we're measuring the amount, we're measuring the color. That is the nursing, responsibility, what it looks like. If the drainage collection system gets full, we replace it with another one. We're monitoring oxygenation status, how they're doing, SpO2, ABGs, and the drainage system. We're managing that. Like I said, it gets full, we put in another one. And we're managing and monitoring pain and comfort, helping them with coughing and deep breathing. If they've had surgery, they'll often have a pillow. Most hospitals give them a little pillow to splint with. Or you can give them a pillow, just a regular pillow to splint with. But they still need, to cough, deep breathe, not just sit still in one place, but to move around a little. And we're monitoring the dressing that goes over the site. I have seen the dressings get, full if there's, something strange going on with bleeding, or I had a patient once who had empyema, which is a lot of infection, and we, the doctor didn't want us to change it, but to reinforce it until he came. So, there are, reasons. There's definitely a need to monitor the dressing. So we're monitoring the dressing, and just points to remember: keep the chest tube below chest level. So that's something we have to collaborate with our PCTs. When you have to give them report, you have to communicate with them, making sure they understand that. An experienced PCT probably knows, but say you've got a PCT that's never worked with chest tubes. So you definitely need to communicate. Monitor drainage. They can help you monitor drainage, but it's ultimately up to you. So as a nurse, to make sure, that you're monitoring that. Milking or stripping the tubing is no longer recommended. We don't do that. We don't clamp it. So just keep that in mind. And if drainage system breaks, we place the end in the sterile aged water. So just remember all of that. And I believe that is, and let's don't forget pain control. So we want to control their pain so that, so that they will do the incentive spirometer, and so that they will cooperate in their care. So that, abdominal trauma. I thought I was done. But abdominal trauma, it can be blunt or penetrating. So, think of a gunshot wound or a car wreck, or blunt, they got hit with a baseball bat. So, when you think about trauma, you got to consider, did they, is it a solid organ involved, which could lead to bleeding, hypovolemia, or is it a hollow organ, like your intestines, your stomach, your bladder, which could lead, your intestines definitely could lead to peritonitis, which could lead to sepsis. A lot of times with that type of stuff, they will need the abdominal lavage, where they clean all that out if they've got a hollow organ that's ruptured in there. And as far as diagnostics, you're gonna of course get a chest x-ray, a abdominal x-ray, or a CT scan, ultrasound. The CT scan usually shows the best for the abdomen. Then of course they're gonna have pain, guarding, decreased bowel sounds, a rigid, hard abdomen, decreased respirations, and decreased cardiac output. And you say, why do they have decreased cardiac output? Well, think about if you've got a bunch of blood or fluid in the abdomen, what's it going to press on? It's going to press on the diaphragm. What's the diaphragm? So you got all that pressure in there. It could affect breathing because of the diaphragm, and then the extra pressure is going to push up into the chest cavity. So think about all of that. It could be definitely could be an emergency thing. So you're monitoring your patient, your respirations, your cardiac output. And are patent. We want a patent airway. They may need IV fluids. They may need blood, depending on what's going on. A Foley, because we want to manage that output, because this can turn into sepsis pretty quick. And then your NG tube to decompress the stomach. We want to leave impaled objects in place. If they get impaled, we want to leave that in place, because what's going to happen when it pulls out? They could bleed out. So that's something they'll remove in surgery under controlled circumstances where they can help them immediately. You want to prepare for emergency surgery, and especially in that case. And you want to prevent prevent and assess for sepsis. Like I said, you're looking to make sure you're putting in the Foley, or you're assessing, checking the lungs, all of that. So these are just the two pictures. The gray Turners is usually when you've got bruising around the flanks, just because of that blood that's pooling, and from them lying down. And then your Cullen sign often is the bruising around the umbilicus. So just be familiar with those. And that's it. And I just wanted to give you a quick review of chest trauma, abdominal trauma, and chest tubes. And you have a great day.